what are the particular health needs of LGBTQ plus people and communities? Well, there are lots of health needs. I think sexual health is one of them. Mental health is also one of them.
Did you know that 71% of aromantic people have suicidal ideation, and that 9% of aromantic people have attempted suicide?
I also think there is a lot of like rather than taking a deficit lens, we also need to recognize the strength of the communities. For example, the creativity, the resilience of the community. It's so important about racism and all this kind of a broader experience of LGBTQ health because I work a lot with LGBTIQ multicultural people. A lot of like identities also intersects with things like culture, things like language, things like all these kind of like broader aspects of racism.
Basic principles is being recognized for one's individual care needs. I strongly believe in Harvey Chochinow's very famous dignity question. When we are talking to a person, I make it my personal practice to ask someone, what's the one thing about you could tell me about yourself to help me provide the best possible care for you? And I put that question to patients to let their doctors and nurses know what's the one thing about them they would like their healthcare worker to actually know. Whether it's their sexual identity, a gender identity or orientation, or anything about their cultural and diverse background, or what's sacred or important to them at this point in their life. That is my wish, and that informs our work as healthcare workers, not just for the LGBTQI community, but as a humanitarian basis of healthcare work.
Why do we need better data on LGBTQ? That's a good question. So I think the main thing is our communities, particularly the more marginalised in the rainbow, we know that we face various health challenges in maintaining good health, but we also have some of the people, particularly trans, where people in this spectrum and people with innate variation in sex characteristics, we actually don't know how many people there are, we don't know where they live, and therefore trying to direct services at them. We need to do better data collection. We know a reasonable amount about the LGB in there, but even actually I think by plus people would say we don't have fine-grained detail, particularly people who live with heterosexual partners, well, same-sex partners. So it's going to be really interesting to see, particularly in the census, where people can actually tell us their sexual orientation, and we can identify transgender people better. And the one huge omission there is that we won't know about people with innate variations of sex characteristics. But yeah, it's a really good first step.
I guess for me, what I see as the unique challenges is the services that people might access and that lived experience that they've had of generations of stigma and discrimination, and the fear that they have that they're going to experience that in the services. I've worked in LGBT inclusion for 20 years. I've seen massive changes, and I think, though, in some spaces we've still got a long way to go. So for me, I'm getting there. Another 20 years and I'll probably be accessing services. So I want those services to be as inclusive as possible, and hopefully that we're well on the way to reducing that fear that people have about services, but also services knowing that we're on our way, we're here, and you need to just get on board.
What does inclusive care look like for you? There's so much that we can do to make care inclusive, and I think that it starts with getting to know people on a personal level. I think it starts with understanding a person's whole life story and what makes them who they are, and then I think from understanding a person's social history you can then tailor care to their needs, whatever they may be. So for me, I'm a proud lesbian woman. Inclusive care for me would be people being aware of the fact that I have a wife, maybe not asking me about my husband, those sorts of things.
So what does inclusive care look like for me as an older person?
It will look like getting to be exactly who I am in every setting. You don't become a homogenous blob when you turn 60. You are still a person. And I am going to age into that, God willing. I am going to be an older LGBTI person. So inclusive care has got to meet me, really. I think that's where we're all working towards.
Inclusive care looks to me like being able to have a relaxed conversation with my exercise physiologist about the fact I do work in the LGBTI space and not be judged. Knowing the organisation that I've gone to has specialisation verification for LGBTI inclusion. So if I know that, I can feel free to just be me, and that's what inclusive care looks like.
LGBTQ plus community-led organisations are incredibly important. So our community knows what we need when it comes to mental health and AOD services. So by integrating our perspectives and experiences into the infrastructure of the organisation, it means that the services that are provided are going to actually be meaningful and meeting the needs of our communities.
So I work in the sexual domestic and family violence sector, and we need specialist responses because this sector was not built with LGBTIQ plus communities in mind. In fact, it was really quite the opposite. So in order to provide services for our community, we need services created by our community for our community.
Being able to nowadays have queer, Indigenous, community controlled organisations and be able to access supports with peer navigators who have similar experiences to me as being invaluable to my life. It's meant that I haven't died in my life. There have been points where if I didn't have the support of people from those community controlled organisations, I wouldn't have survived.
Community-controlled organisations are so important because they understand community exactly where they're at. You're going to have better outcomes, better solutions, and things that will last longer if it's driven by community.
Conference has been really interesting. So one of the things I always get is that you see the huge range of work and programs. But one of the things that you also see is that those programs are very well resourced, and then extending them beyond where they were first done is one of the huge challenges. So I work in HR and there's been 30, 40 years of investment. And even in that space, we argue about consistency. So we at least do have a national mechanism, state mechanisms, and stuff. And in the queer health space, people who are less well represented in there, you hear about amazing programs in some cities and towns, but they're not available in this country. If we're serious about health for all, how do we extend their kind of strength space? See great examples of where we can't get everybody to excel.
People working in our sector are having to really think about creative ways to fill gaps and figure out ways to work with limited resources, often in an environment where they haven't been given the tools and they haven't been given the greater levers to do that work. So coming to a conference like this, networking with other people, other organisations doing similar work, we can learn from each other about how they're managing and creating these innovative approaches. The LGBTIQ plus community is not one homogenous community, and so we cannot have one homogenous response to tackling violence or any of the issues that affect our communities.
We're still working hard to try and get to community. I think there's been some great moves with the government in changes in that space. I think they've engaged our peak bodies and have listened to that. But I still think there's a disconnect between that and grassroots, which is where I sit, and trying to provide this information, empower our communities, and break down the social isolation that's still occurring and is a big preventer, big barrier to accessing good health and well-being and living the best life possible.
The biggest thing in LGBTQ plus health is that we need to use protection. We have to get condoms in residential care, but more than condoms, we have to get dental dams. We have a new generation of aging coming into residential aged care. We have sexually transmitted diseases running right through retirement villages. Older people are still being intimate. We have to protect their health.
It's been a privilege as the MC for the Comprehensive Health Indifference and Ageing Indifference to share space with so many members of my communities, and in particular elders of my community, and to hear and share stories with them and experiences with them. I think it's been really empowering and affirming to know that we have so many champions of change in one location right now and right across Australia, making sure that our communities, our LGBTIQ plus community, experience health equity and access. And
being together with my tribe, it is so important, especially people that are on their own in communities, in remote or communities like that. There aren't people visible for us. So I come to my tribe. I love coming to my tribe because I know I'm safe.
But I think the key takeaway is just how strong a network is. So people out there doing the research, doing the conversations and connecting with the community to try and make really positive change. And for me to be part of that and have the opportunity and to come and meet people after this event is fantastic. It's just so good. And their connections and relationships they'll take away with me and keep me going. But also to connect with people I haven't seen for a long time as well. So it really is, I think, coming to these sort of events is where you find your tribe, and your connection, and it gives you that real sense of, you know what, we're pretty strong.